Hello everyone and welcome. We're going to get started with our latest webinar in the Supporting QI webinar series presented by the Excellence Through Quality Improvement Project. And this webinar we're going to look at using the OPOC tool as a tool in quality improvement. Before we begin, I would ask that if you could take a moment in the chat box and just type in the number of people at your location who are taking part in the webinar, just to give us an accurate idea of who's here and how many folks are here today. I see that Rue at Oak Center has already done that, so thank you very much, Rue. You're ahead of the game as usual. So some technical information about the webinar. You should be able to hear us, hopefully, through your speakers on your computer. There is a call-in number as well, if you'd prefer to use that, and your line is automatically muted on the call-in. We'd ask that you hold all your questions until the end of the presentation. Just in terms of keeping the flow going, we'll address all questions at the end and allow some time for some discussion. As you have questions, though, you can enter them in the chat box, and Jenna here at CMHA is very kindly going to keep track of those questions, and then we'll address them at the end of the webinar. All of the material, PowerPoint presentations, and items discussed today will be shared and made available to you via the E-QIP community of practice. We'd also ask that you take a moment at the end to fill out a brief feedback questionnaire so that we can continue to improve these webinars that we do in future. And Jenna will share that link as well on the chat dialog box at the end of the webinar. So a couple technical pieces. You can enlarge or make your menu box smaller with that red arrow, and you'll see there's audio control options there for you, either through the telephone or your mic and speakers. So you may want to make sure that's working. And there's the chat box located down near the bottom, and it expands out so you can type in your questions and follow along there as well. So we're very lucky today to have an expert group here that's going to share their experiences and insights into the OPOC tool. And I'll introduce you to the folks that will be speaking. I'm, of course, Michael Dunn, Director of Quality Improvement here at CMHA Ontario and co-lead for the E-QIP initiative. And to my right on the screen is Kim Baker, and Kim is with CAMH, and she's the implementation supervisor with the DTFP program. And to Kim's right on the screen is Christine Babcock, who's Director of Supportive Housing and the Accreditation Coordinator for CMHA Middlesex. And the mystery man to Christine's right is Kevin Acuna, and Kevin is also with the DTFP program at CAMH, and he's a bit of a mystery. We don't know quite what he looks like, but he's maybe the man in black. So, and as far as that agenda today goes, I'm going to begin with just a very brief overview of E-QIP, and then Kim and Kevin are going to take it, and they're going to walk through the OPOC and the implementation of the OPOC. Christine's then going to share her experiences from CMHA Middlesex, and then I'm going to come back and talk a little bit about my experience with the OPOC and using it for quality improvement at CMHA Simcoe County Branch, which is my home organization. And then we'll open it up for questions and discussion. So as I'm sure everybody's aware, we are the Excellence Through Quality Improvement Project, or E-QIP, and we're an 18-month pilot initiative between three partner organizations, CMHA Ontario, Addictions and Mental Health Ontario, and Health Quality Ontario. And we're the first quality improvement initiative of its kind in community mental health and addictions. And we're hopefully supporting and trying to support as best we can the growth and development of quality improvement within our sector. And we offer a number of different offerings to help do that over this period. We offer quality improvement and data coaching, access to tools and resources, and educational offerings, including the Supporting QI webinar series, which this, of course, is one. So the Supporting QI webinar series, we're going to be doing and have been doing monthly webinars aimed at topics that are relevant and of interest to folks exploring quality improvement. We've done things looking at leadership and culture around QI. We did a session last month on using the OCAN tool for quality improvement, and then of course today's session. We want to hear from you though. If there's topics for webinars or ideas that you have of things that would be valuable, let us know. We can try to offer a webinar dedicated to that. We do have a webinar that's in its final planning stages for the very end of March with a date to be determined. And we're going to be looking at data quality and using data and different data means that are available to us to inform quality improvement. So we're very lucky to have our E-QIP data coaches who will be leading that session. So please stay tuned for that. So without further ado from me, I'm going to now pass it over to Kim and Kevin to lead you through their part of the presentation.
Great, thanks so much, Mike. Hopefully everyone can hear me okay. Oh, I've lost the slides on my screen, so I'm not sure.
Oh dear.
That's the key for everybody, but while you do that, I can introduce myself. So my name is Kim Baker, and I'm an implementation supervisor with the Provincial System Support Program at the Centre for Addiction and Mental Health. So Mike referenced earlier DTFP, which is a drug treatment funding program, a Health Canada funding envelope that actually allowed the work around OPOC to get started. The DTFP program actually no longer exists under the umbrella of Health Canada's anti-drug strategy. So the Provincial System Support Program at CAMH is continuing to support this work, the implementation of OPOC, and there's a top-notch implementation team at CAMH within PSSP that's supporting the work. So I also want to thank Mike and his team, Kim and Jenna, who have supported the development of the webinar today, so thanks. And I'm not sure I'm able to move the slides. There we go. So what is the OPOC? So the Ontario Perception of Care tool for mental health and addictions is a standard validated tool. And essentially it's meant to gather perception of care feedback from across mental health addictions and concurrent disorder programs, both community and hospital. So in the development phase of OPOC, the Ministry of Health gave us a very specific direction around ensuring that this could be applicable across a broad range of Ministry of Health or LID-funded providers within the sector. Just sort of wanted to distinguish perception of care from client satisfaction. So client satisfaction is more related to whether someone liked or didn't like a particular aspect of care. But the OPOC asks about perception of care as it relates to what should be expected as standard quality practice. So it's just a little bit different. So why the Ontario Perception of Care tool for mental health and addictions? Really, it's intended to bring client experience, patient experience as a form of evidence to inform positive system change. So it captures information on quality improvement indicators across some key domains and can contribute to program and system level quality improvement. And the quote there from HQO comes from their 3-year strategic plan, really punctuates that patient outcome and patient experience really are great indicators of a higher low quality healthcare system. So it's really important to be gathering their perception of care from service users. And I think the unique thing about OPOC is that it allows a standardized way to do that. In the research and development phase, the Dr. Brian Rush and the team in the research department at CAMH did a scan across the province, and certainly a lot of folks were gathering feedback from their clients. But it tended to be in very disparate ways, so it was highly variable in terms of how people gather that information. So the OPOC allows a standardized way to do that, which can roll up the data for use at a system level. So you have sort of multiple levels of opportunity for improvement. I'm trying to move my slides, but I'm not having much luck. No, I've gone too far. Okay, so there's two versions of the OPOC. One is a registered client version, so a 38-item version. It takes an average, the average is about 12 to 13 minutes, but anywhere from 10 to 20 minutes to complete. And this is completed by folks who are receiving services for their own treatment or support. So this may include somebody who's a family member or a significant other, but they're registered in a program to get support. And then the non-registered version is a bit of a shorter version. And it's really for folks who might be connected to some service but not registered. So for example, a parent who might be involved in a parent information sessions or psychoeducational sessions. This may be folks who drop into peer support programs but aren't quote-unquote registered users of the program. So the distinction here is around sort of the level of connection to the particular program. So I will also note that the registered client version has 6 items that are specific to inpatient or hospital-based services, and those items simply wouldn't be completed by folks who are not in inpatient or residential. And it's important to remember that people are answering from their own perspective and not answering about care that someone else has received. And we realize that there's absolutely a need to get feedback from family members who are caring for folks who may be substitute decision makers, for example. And we've actually identified through our implementation process some of the populations that the OPOC doesn't apply to. So there are certainly some service pockets where we've talked about potential future customizations of OPOC. But for now, these two versions are really about gathering feedback from a person from their own experience, from their own location. So there's a number of domains within OPOC. So access and entry, services provided, participation and rights, the therapist, support worker, staff, the environment, the experience of leaving the program or discharge, if in fact the person has reached that point, and then their overall experience. There's also additional questions about age, gender, ethnicity, and sexual orientation, and this helps us to look at the experience of care through the lens of health equity. And already in the early pilot days, there were some differences in how various groups experienced their care. So being able to view this through the lens of health equity is a really important aspect. There's also open-ended questions about the least and most helpful aspects of service. So service users can add some anecdotal comments as well. The OPOC sort of has 4 key requirements or administration essentials. Because it is a validated and copyrighted tool, it must be provided in its entirety. So you can't extract questions from the OPOC. You must provide the entire questionnaire. Again, it's validated and copyrighted. Now, clients absolutely can elect not to respond to certain questions if they don't feel comfortable doing so, or they feel it's not applicable to them. They can choose that option. But service providers aren't to sort of edit or limit what is provided to the client. Completion is voluntary, so it's not at all connected to the service or access to service. It is an anonymous questionnaire. We did an external privacy impact assessment that really helped to guide us in the development of the database and our processes to ensure that we protect client privacy. And then to provide facilitation only as needed. So facilitation meaning support to help the person understand the question, but not support to help them select a response. The tool is available in English and French at present, validated for clients 12 and up, and appropriate for around a grade 6 literacy level or higher. So I mentioned that we did a privacy impact assessment externally, and it did help us to sort of shape a lot of the documentation around the OPOC and how it's being implemented. So we've developed a memorandum of understanding and a client information sheet that's really intended to clearly articulate the role and responsibility of CAMH as a custodian of the data, but also of service providers in terms of protecting client privacy. So there's a variety of ways that data collection can occur. We're working sort of on an organization by organization approach to support the development of a plan that works for that organization. So the administration approach and the timing of the administration is really context dependent, based on the type of organization, how people come to care, how long they stay there, whether that particular client population has specific support needs in terms of completion, etc. So the data is collected and analyzed centrally. So our partners at DATIS, the Drug and Alcohol Treatment Information System, have helped us to build a central database. So this database, though DATIS helped us build it, it is not connected to DATIS. It is not connected to any database that has personal health information. And again, this is the intention to protect client privacy. And it's a database that is accessible to all in-scope agencies. So that is all addictions, mental health, or concurrent disorder providers in the province of Ontario that are funded by the Ministry of Health and Long-Term Care or via the LIM. So that's about 500 agencies across the province, give or take. And as I said, we have implementation coaches that support the development of an implementation plan for each agency. So this is really meant to take into account agency context. You can imagine within 500 agencies that range from everyone from CAMH is a large hospital to very small community-based organizations. There's a lot of variability in how people access service and how those organizations provide service. So the implementation plan is dependent on the agency context. It also looks at programs distinctly. So again, there's organizations that are particularly larger organizations that have a wide variety of programs that they provide. Some large CMHAs have 15, 20 different programs. CAMH has dozens of different programs, for example. And if we're really wanting to keep in mind the principle of collecting this information, so it's not just collecting data to have data, it's collecting data to use for quality improvement. And in order to be able to do that, we have to actually distinguish between programs within agencies that are distinctly delivered and have perhaps a different target audience. So each program within each organization has a separate code so that organizations can look at each program distinctly and separately and drill down on their data for QI purposes. Again, the plan has to protect client privacy, so we're guided by that external privacy impact assessment that we completed prior to getting implementation underway. It honors those 4 administration essentials that I mentioned. We endeavor to support the development of a plan that really maximizes how many service users can provide their input. And certainly this is a learning opportunity. There's been organizations that have done sort of one round of OPOC implementation, come back and do some re-examination of the plan to make sure that they've really optimized the input that they're receiving from their service users. And then we also ask folks to articulate how the data is going to be used for QI purposes. So who's going to review it? Whose responsibility is it to take a look at the OPOC reports and to determine what changes, if any, are required as a result of them? So I'll give you a really quick implementation update. You'll see the date there as of February 28th because this changes every day. We're working in all 14 LINs across the province. As of the 28th of February, we have 80 agencies from 11 LINs already have data in the central database. We have about 145 memorandum of understanding signed by organizations. 125 organizations have their specific agency implementation plans complete. And as of that date, we had 5,931 completed questionnaires, OPOC questionnaires from across the province. 602 of those were non-registered clients. 1,577 were from inpatient or residential treatment programs, and 3,752 were from outpatient or community-based service providers. So you can see there's already a significant amount of information within the database that has rich possibilities for system-level quality improvement. So some key next steps include orienting our providers to the reports. So we've built not just the database, but also the reporting portal that all organizations using OPOC have access to their own data in real time. We're also developing a LIN reporting portal, so we'll be launching that and providing orientation in the coming month or so. We've also been in conversation with NRCC, which is a contracted patient experience survey provider that some hospitals use, and we're working with NRCC to see if we can develop a data transfer mechanism that will allow easier use of OPOC for hospitals that use NRCC as part of their patient experience survey approach. And one of the exciting next steps is a bit of a pilot that's a spin-off from OPOC that will be taking place in the Southwest LIN. It's called the Continuous Quality Improvement Collaborative. So this really is an extension of our implementation work around OPOC. And this will bring providers together within a defined geographic area to collectively look at the OPOC data for quality improvement purposes. And again, this is the primary objective, that by bringing client voice, service user voice forward as a means of evidence, we'll be able to support quality improvement efforts across the system. So in about a minute, I'm going to turn it over to Kevin Acuna, who's an implementation coach and a research analyst on our project, and he's going to give you a live demonstration of the OPOC reporting portal. So again, I'll just give you some of the basics before he gets underway. So the website is accessible by all organizations in the project. No information for under 5, cell sizes less than 5 won't be reported. As I mentioned, all providers have immediate access to their own raw data, including the open-ended comments. We've developed aggregate reports for similar programs across Ontario, and the LINs will have access to the quantitative data. So I will turn it over to Kevin, who's going to sort of give you a quick walkabout. Certainly, we don't have time to go through the entire database and all the different aspects. We'll give you a quick snapshot, though, of what the database looks like.
Okay, hi, everyone. Just want to make sure people can hear me before I continue or move on. Okay, perfect. So as Kim mentioned, this is the OPOC reporting platform. There's a ton of different reports that are actually generated through the OPOC reporting platform. So here I just call them reporting tabs, as you can see here at the bottom. I don't know how big this looks on your screen, but there's about 9 of them. So each one provides different data. It provides it in different formats, and I'll show you what that looks like in a sec. And we've also included on this reporting platform, from some of the feedback we got during the pilot, some comparable data across the province. So as you'll see here at the bottom, and I'll point it out as I go along as well, the tabs alternate. So for example, this is the first page once you go into the reporting platform, and then if you click on the next tab, it'll show you the exact same data, but for the entire province. So in there, you'll be able to sort of see how the OPOC data looks like provincially. You'll also be able to drill down more specifically. So if you want to look at, let's say, how all female clients the age of 18 to 25 are doing, or what they're saying across the province, you'll be able to look at that and then compare that to your particular clients that fall under that group as well. And there's some other filters that I'll show you in a sec. So the first page here is just laid out based on general overall picture data. So it'll tell you how many registered clients have completed the OPOC at your agency. So right now, currently in the province, this is the number, so 5,368. It'll also give you a breakdown of how many registered family members, significant others, or supporters filled out the OPOC. It'll give you the non-registered client, again, based on the two versions of the OPOC. And then lastly, it'll give you just the total number of respondents. So as Kim said, that number is constantly changing. So from the slide she showed, it's about 5,800. Now it's at a little over 6,000 OPOCs in the database. And there's 8 different domains in the OPOC. So that's how your data is laid out when you initially go into the reporting platform. So it'll give you, again, so the first area is access or entry questions. So it'll show you the responses for the first 6 questions. They'll let you know, again, the breakdown from strongly agree all the way to strongly disagree, how many people said not applicable. The number of total responses here is the total number of people that responded for that question. So as you can see, that number is a little bit different than the total number of OPOCs. And so that response rate next to it is based on this and just divided by this one. As you'll see, as some questions, some people, there tends to be a lot less responses for certain questions. So again, I'm just going to show you here. So based on the 8 OPOC domains, so you got the service provided questions that are highlighted here, the participation and rights section, the questions about staff and workers at the agency, the clustered asks about the environment. Then you have discharge or finishing the program. You have the overall experience questions. And then lastly, the inpatient or residential program questions. So again, this end is going to be very different from the one you saw at the top, or even from some of these numbers, because these questions are only answered if someone's in an inpatient or residential program. So you have all that data once you get into the platform. And I hid them here just to make things a little bit easier to see. Okay. So there are some filters here on the left-hand side. So unfortunately, right now they're not showing up. Maybe when I jump to another tab, they'll show. But there's a number of ways that you can filter all this information that you saw here. And most of the filterable options are based on the OPOC demographic questions. So there's a filter that looks much like this, but it has all the age categories from the OPOC. It'll have sexual orientation as well. It'll have gender in there. It'll have those population groups. It'll have this one, which is sadly the only one that's showing right now. So registered clients. So it could show you just the data for your registered clients versus the non-registered clients who answered the OPOC. And then, of course, you can drill down to the program level. So when you go in there, you'll be able to see all your programs, and you can filter the data based on the individual programs at your agency. And then there's another couple of filters that associate with the OPOC keys, which is campaign name. So let's say, for example, you're administering the OPOC across a blitz, and you're also doing it ongoing. So you can filter your data to just look at all your blitz data. So let's say you did it the entire month of March. You can just isolate your March data versus sort of the ongoing data if you decide to do 2 different kinds of administration approaches. So the next tab is, it provides you information about your client demographics. Just give it a sec here while it loads. The information there that's provided is based on, again, some of the demographic questions directly from the OPOC. So it'll give you a breakdown of the client demographics. So it'll give you a table showing you, how many females, males, and so forth, and then it'll give you a table. And unfortunately, there you go. So again, like I said, from the OPOC demographic questions, so you get a table showing that distribution and then a graph. So there's a couple here. So it's gender, there's age group, there's also population group, and then lastly, it'll show you sexual orientation. And then there's also down here just some treatment demographics. And I'll show you quickly two other tabs just for the sake of time. I see I only have a couple minutes left. So you can directly pull your comments from the reporting platform. So they'll be displayed like this based on, again, the different domains of the OPOC. And so you'll see all your comments that fall under the different domains. And then lastly, there is an additional helpful data tab. So here is, you'll get a quick snapshot of a response rate. So this response rate is based on the number of keys that you download and distribute on the website, and then how many are actually completed by clients. So you can see this is what it looks like provincially. And here we've included a couple of different tables and graphs to help align with quality improvement initiatives. So the first one is a graph and table that you can customize yourself. So in here you can include any of the OPOC questions, and you can track them over time. So that's why we called it top priorities for the coming year, because it'll give you a breakdown of the distribution of responses. It'll give you the graph. But the great thing about this is you can sort of track your QI initiatives using specifically this part of the report. So for example, some people have implemented a change with how clients provide a complaint at an agency. So they would pick that question from the filters here. So you just click on, that's specifically question 16, and then it'll show up here, and then you can track that over time. So as you're making those, as you're implementing that quality improvement initiative, you can sort of see what your OPOC data looks like before and then after. And then in here, we've also included two other tables. So one is areas of excellence. So these two are auto-populated. So the first one just highlights the 5 questions where you had the highest score of strongly agree and agree. And then there's the areas of improvement. So this will show the areas where you scored the highest level of disagree and strongly disagree. So people tend to gravitate quickly to those graphs just because from here you can just look at a quick glance some things that you can already start looking at from a QI lens. So what tends to be a very common one, which is why I use question 16 as an example, it's because a lot of times it tends to be in this graph. And then lastly, it'll show you the OPOC subscales, which came out of the pilot work for the OPOC. So Mike, you can take over again.
Great, thank you very much, Kevin.
No worries.
Kim, is there any last comments you wanted to make before we move on to Christine?
Yeah, I'll just flag that these are some of the key contacts for OPOC. So my contact is there at the bottom, but each LIN has an assigned implementation coach or coaches that you can reach out to. So they're listed here. So feel free to be in touch with us with any other questions that we're not able to answer today.
Great, thank you so much, Kim and Kevin. So we'll now move to Christine, who's going to share her experience from CMHA Middlesex.
Hey, hi, I'm Chris Babcock, and as Mike said, I'm the Director of Supportive Housing for CMHA Middlesex. I also have the title of Accreditation Coordinator, which also includes most of the quality improvement stuff on the side of my desk. So today I'm going to just talk a little bit about our experience with the E-QIP project and also how the OPOC has become a part of that. So a little bit of background. We applied for a quality coach through the E-QIP project and got both quality coach and a data coach for access to service. And that was our improvement project. And that was basically based on our operational goals for the year. We recognized that we had wait times in most program areas, but notably at the time in our case management program in London. So we have a project lead and an executive sponsor, which is me, and we've attended multiple training sessions with the E-QIP. And then simultaneously, we were implementing the OPOC through the agency. So initially, we didn't see a fit because we weren't actually looking for one, but we recognized that the voice of the person served is essential to quality improvement. So where we started was our project charter, and the problem statement was created using information from one of the E-QIP exercises that we did, the fishbone exercise, where we found what was the root cause to all of our wait times. Very recently, we added the word avoidable in there for avoidable wait times, and that was after actually participating in one of these E-QIP webinars and realizing that just kind of honed it down a little bit more, because there are occasions when wait times are unavoidable. And what you'll find as you go through quality improvement, if you're using a project charter like this, is it goes through many iterations as you kind of hone in on what your project's going to be and what the actual improvement is that you want to see. So this is probably about our 4th iteration, and we added the word London because as we were doing it, we recognized we actually have case management in Strathroy and Exeter and other rural sites, and we weren't actually talking about access to those services, so we had to fine-tune again and add the word London. This is an example of the fishbone that was created, and this was created by the full project team. So our quality improvement team has direct service workers, so our intake workers are in it, as well as our case managers, and then there's some management representation, and then myself sitting at the table, not being a part of case management or intake, so that outside eye. This session was really productive, and the next step from that meeting was to meet with our quality coach and to begin a driver diagram to get at some of our change ideas. And the project lead and I had created a fishbone during training, so this is kind of interesting. And it was different to the fishbone that was created by the team. We had a lot of the same causes, but the bottom line was when you come in with a larger group and direct service personnel, they come up with a lot more ideas and concepts for what the root causes are. So this is the 5 why exercise. So when we looked at some of our root causes, and this 5 why was created by the project manager and myself, again during one of the E-QIP training sessions. And we based this on 2 of our root causes that we saw from the fishbone we'd created, so not the one I just showed you. But the final whys and the final actions in both of the 5 whys that we created were the same, which made us realize we're actually on the right track here. And then the final actions of our 5 why is actually going to be the same action likely that's going to come out of our project team's 5 why. So I think we're pretty much on the right page there, and it's still a work in progress, but we're doing really well. And the next step that we have is going to be creating a process map that's going to talk about our preferred state of what we think access to service should look like based on what we see is wrong with what we're currently doing. So on the project charter, you also have a section in there on measures. So how are you going to measure the improvement? And that's where the OPOC fits in. So we have outcome measures, and that's obviously going to be wait time from our referral to service initiation and case management. And then process measures, which are going to measure your change ideas. So what are you doing and how do you measure that? A big component of the project charter, though, is the balancing measures, and this is where the OPOC would come in. So for our QI project, the OPOC's going to be using, we're going to be using the OPOC as a balancing measure. Balancing measures are the changes that we're making to one part of our system, so the intake system, and seeing what other areas that's going to impact. So if we make changes to access to service that are going to be a quality improvement idea, access is going to be better, wait times are going to be shorter, one of the things we have to make sure is that the individuals we're serving are perceiving it as that. We may have numbers, but the person served might be going, this system is terrible, I didn't like the way it happened. So that's where the OPOC comes in. The OPOC has the entire section, as was described before, on access to service. So the first 4 questions around the wait time for service, when I first started looking for help, it was there for me, locations were convenient, and I was seen on time. Those are directly related to our quality improvement project on access. So it would be prudent for us to ensure that we're collecting this data using the OPOC. And the last 2 questions, feeling welcome and receiving enough information about programs and services, basically that's our philosophy. So we're going to ask those questions as well as part of this quality improvement project. And we have access to the report suite now too, so we'll be able to compare our results with the province. So some of the lessons learned as we're moving through both the quality improvement project as well as implementing the OPOC is that people do want to move fast. In this agency, they see a problem and they come up with a solution immediately. But moving fast doesn't allow time to really assess what the root cause is. And so when you use the tools that E-QIP provides, the 5 Whys, the fishbone, the charter, it takes time to complete those exercises, and it leads to more effective change ideas because you're not just jumping the gun and coming up with a solution without really taking the time to think about it. Rushing doesn't allow the time to collect the current data, and without current data, you can't compare to see if there's actual improvement. There also may not be a problem when you actually look at the data. It might just be something that you think is an issue, and then the data proves otherwise. And also having data allows you to add contextual information to that data. And then, filling in all the sections of the project charter. So that's helpful because, again, that slows down the team. It makes you look at those balancing measures, and you make sure that everything's being addressed through your change idea. And then we also learned that the project team, the makeup of that team can be challenging. So you do need direct service staff, as I said before, and leadership at the table because leadership can push it through. But you want the direct service to have a vested interest and to have buy-in. So they all need to be at the table. That said, too large a group can really delay the process because you get so many ideas and it can become overwhelming. But too small isn't going to give you enough input. So that was demonstrated when 2 of us worked on the fishbone versus our project group, and they came up with some better ideas and additional ideas. Having an improvement advisor that's not a direct staff person in the quality improvement project is also very helpful because you have that outside eye and you have the ability to kind of bring your team back on track without it seeming like you have a bias because you're actually part of the program that you're trying to do an initiative on. So they're more objective. And another lesson that we learned that's not on my slide is with the OPOC. So implementing the OPOC. And one of the things that we noted was the number of staff that we initially give access to as data entry or admin, so people who can make the keys that relate to your specific program. It changed. So initially we had a few people. We didn't want it to be cumbersome, and it grew and grew. As the programs began to use the tool, they were finding out what flow worked better in their program area and requesting additional people have access to be able to enter the data or to be able to create the keys as we implemented it. So we had this thought in our head about how it would work, but reality actually changed that. So you need to be open to being flexible with that, adding people, and really listening to each different program area for what's going to work for them. And as well, one of our bigger delays in moving forward with the OPOC was trying to get people to watch the webinar and access it. And now it's actually available, and you can have the file so people can watch it on their own time. So that has really helped pick up with programs implementing the OPOC. And that's all I've got.
Thank you very much, Chris. That's fantastic. I'm going to take a few moments to share a bit about the experience of CMHA Simcoe County branch, which is my home branch. We were one of the early adopters or early pilots for the OPOC, as we've been doing it for a number of years now. And I get so excited when I hear Kevin and Kim talk about the portal and the availability of data in there, because it's my experience prior to that has always been taking all the OPOC surveys, entering them into Excel, and analyzing them with SPSS, which is extremely time-consuming. So it's extremely exciting to hear about the work you folks are doing and how that's going to help us get faster access to some meaningful data that we can use for improvement. So CMHA Simcoe County is primarily located up in Barrie, Orillia, Midland, in that region. And it's worth noting that Simcoe County branch is an integrated agency, both mental health and addiction services, and really across the age spectrum from young folks all the way up to older seniors. And we serve LIN 12, which is the North Simcoe Muskoka LIN, and it's a very diverse region geographically. We have larger cities like Barrie, but also very small communities up in the north, located north of Penetang and such. Approximately 300 plus staff and 131 volunteers at the agency. It's also a relatively large CMHA in the province. And in terms of the types of services offered at Simcoe County branch, there's really a broad range, everything from youth justice to transitional housing to opioid treatment. We have both ACT services and early psychosis intervention services. We're also responsible for the region's crisis line and mobile crisis program, as well as a fuller range of case management and justice services. So very broad range of services at this branch. In 2015, so this is a little bit older, we served almost 8,000 different clients through the agency and responded to over 14,000 crisis calls. So the demand and volume of service in our region is quite high. As I mentioned, we've been using the OPOC for a number of years and using it across all of our different programs to try and capture consistently some data around the experience of receiving services. So these numbers are from 2015, so they're a little bit older, but give you a sense that some programs have found it much easier and are much more able to get responses to the OPOC survey, where some programs have struggled with that a little more, programs like the early psychosis intervention program. So this is the results of just one of the blitzes that we did. And I know Kim mentioned during her presentation that PSSP is currently exploring avenues to look at if the OPOC could be further adapted or customized for different populations. So that's exciting to hear as well, given some of our experience. So the one way that we've really used the OPOC survey is to look at our agency as a whole and kind of roll up what the experience overall is for folks who come to us for service. Our overall satisfaction rate, obviously from those who report on the OPOC, is reported as extremely high. However, it's important to note that when you drill down to some of the individual items, you can start to see some opportunities for improvement and continuing to get better. So one of those areas was around clients understanding how to make a formal complaint. And as Kevin mentioned, this is a relatively common one, it sounds like. So this, for us, 18.5% of clients didn't know how to make a formal complaint. That's pretty significant, and that aligns with our client-centered domain of quality. And being able to pull out data like this or indicators like this as a flag can then help us prioritize our quality improvement plan for the year. So this may be a goal that we want to address by our QIP. Also having other indicators on the OPOC, such as folks' reported wait time and location of service, can help us as well as we plan our QIP and our various improvement plans for the year. The other area where we've used the OPOC quite consistently is looking between programs. So this example is in response to the question, I received enough information about the programs and services available to me. So as you can see, some respondents from some of the programs rated that very high, others still high, but less so. For example, the HI or Housing Initiative program was 72% of folks who agreed with that statement. So that tells us that possibly within that program, that's something that we'd like to look at for improvement within the program. And then having the opportunity to look across at how others are doing in these areas comparatively, we can try to draw upon our peers and our other programs to see, what's working well, in the case management program, for example, or in the justice program, and how might I look at spreading that to my program so that I can improve in this area. So that too has been very helpful. And then thirdly, within each program, being able to roll up the results for the OPOC surveys and look at opportunities for improvement. So with respect to this specific program here, this is looking at question 32 and whether folks agree or don't agree with the statement, staff help me develop a plan for when I leave this program. And what you can see here is 15.4% of folks disagreed with that statement. So again, that flags for me as a program manager an opportunity for perhaps some deeper dive into what exactly is happening. Maybe I want to look at a process map around my discharge process and try to identify some areas for improvement within my program. So what's next? Well, that's quality improvement. We have these big flags showing us that there's something maybe that's not as good as we'd like it to be. The next step is to then try to make improvements on that. And E-QIP and of course CMHA Simcoe have adopted and used the model for improvement, which is a framework to walk through any challenge that we're looking at or an improvement that we'd like to make using a structured framework of tools, all the way from preparing to even embark on a quality improvement project, through defining the problem, measuring and understanding our system and what's at play, trying to develop some meaningful solutions, and then testing those via rapid cycle PDSAs, and then trying to spread and sustain what we learn. So all of these tools in this framework too are available in the community of practice, all of the quality improvement tools that we talk about. So this isn't, we're not going to use a real example, but we'll take the point from the survey mentioned earlier, the flag that 18.5% of CMHA Simcoe clients indicated that they did not understand how to make a formal complaint. So taking that flag, we'll kind of dive into that, but not using real fishbone, but to show the application of quality improvement tools to this problem. So one thing worth mentioning too is, depending on your flag that you're receiving in the OPOC, in the area that you'd like to explore, you may also want to consider other forms of data collection to help inform your quality improvement. The OPOC is a fantastic tool for gathering a large breadth of information, but sometimes it's also important to capture that depth of information. So looking at things like focus groups, experience-based design, which looks at capturing the client experience and understanding that experience to help guide improvement. So you may want to consider some depth measures as well. So with my problem of 18.5% of respondents not knowing how to make a complaint, I want to take some time to go to my quality improvement toolbox and think about the different tools that I have available to me to help define that problem and look at where to begin. So we want to get down to the root cause, and for this reason, the process map can be very helpful. So that's looking at the flow of people or information through a system or a process. So maybe I want to look at my my process from when folks enter to when they leave, and where are some opportunities to remind them of the complaints process and how to make a complaint. Maybe I want to use the fishbone tool, which helps identify the number of contributing factors. Not just moving to the one that we think is the problem, but trying to identify all of those different potential contributors to why folks don't know how to make a complaint. Or look at my 5 whys, which helps me drill down to the root of that problem. And then applying the Pareto to look at which areas are going to get my biggest bang for my buck. So I'll walk through these very quickly. So for this challenge of folks not knowing how to or not being able to make a complaint, selected the fishbone tool. So on the right-hand side, I've put my problem statement, which is during 2016, 18.5% of CMHA clients indicated that they did not understand how to make a formal complaint. And then working through with a quality improvement team made up of both clients and service recipients and staff of the program to look at what are those possible contributors to why folks don't know how to make a complaint, and trying to list all of the ones that we can come up with as a group. So you'll see things like no complaint box being there, no signage to remind people that they can make a complaint, staff not informed about the complaint process, etc. Now for this example, with the team, we would have the team vote on which of those data points they think contribute the most to our problem. There may be some that clients who are participating feel are more significant than others, and having that voting system to kind of flesh those out would be helpful if we look at how to plan our improvements. So once everybody's had a chance to vote on those factors in the fishbone, we can use the Pareto template, which again is available in the community of practice. And essentially this is just a bar chart which takes all of the reasons in our fishbone that we identified, and we organize them from those that were most frequently voted upon to those that were least frequently voted upon, and hones in on the ones that will give us the 80% result. So where do people think are the biggest contributors to our problem? And usually, by tackling those, we're going to get the biggest result in our improvement. And so in this example, folks identified that clients not being informed of the complaints process, no signage about the complaints process, and no communication policy about how do we tell clients about the about the complaints process were the 3 biggest contributors to our problem that we're seeing. So we'll focus in on one of those and take it a little bit further. And to do that, we're going to apply the 5 whys tool. So looking at that first piece in our Pareto, the first one that was identified as the most problematic, and that is clients not being informed about the complaints process. We can apply the 5 whys and drill down deeper into why that is. So clients are not informed that they can make a complaint. Well, why is that? Well, staff are not informing them. Again, we ask, why is that? Well, staff are not sure of the complaints process and policy. And again, we ask, why is that? Well, managers are not setting out clear expectations and messages. And again, we ask, why is that? Well, managers are not sure of the complaints process and policy themselves. So it helps you get to a meaningful place to start to look at where you might make a change. Helps to focus a little bit. Taking this a step further, we can then apply the driver diagram to look at both our big dot, and that's our OPOC item, the number of clients who report that they know how to make a complaint, and setting an aim around that big dot. So for this example, we've said that by June 30th, we want 90% of our clients to report via the OPOC that they know how to make a complaint. And that would be a pretty significant improvement for us. So we then ask ourselves, how are we going to do that? And we look again at our Pareto with our 3 most frequently identified causes of our problem. And we come up with aims respective to each. The first being by May 15th, 100% of clients will be informed by counselors as to how to make a complaint. The second being by March 15th, a communication policy will be finalized for 100% of programs. And the third being by April 15th, 10 locations will have visible signage on how to make a complaint. So trying to address the 3 biggest things that we identified in our fishbone in our Pareto chart. And then again, asking how are we going to do that? We can take the first one, and that is clients being informed by their counselor, and go to our 5 whys and say, well, we noticed that our counselors were not being trained. So by May 1st, 100% of counselors will be trained on our complaints procedure and process. And so hopefully, if that's done, it'll help improve the number of clients who get informed of the complaints process, and that will therefore increase the number of clients who self-report they know how to make a complaint. And we develop our change ideas with respect to that. The first being that managers will be trained on the complaints policy, because we identify that in our 5 whys as being a barrier for us. It's important to note that there's usually multiple secondary drivers, and there definitely will be multiple change ideas for each of the primary drivers. So we may also want to tackle, for that first one, of clients being informed how to make a complaint. We may also want to have things like a prompt on our intake forms to inform or to remind our counselors, to inform clients of the complaints process. So other ideas that are still going to feed back to that primary driver. And then we want to, of course, have meaningful outcome measures for each one of those, so we know if they're, if they're actually increasing, and if that's lending to an improvement in our outcome measures, which are the voice of the client, ultimately clients that report that they know how to make a complaint. And as Chris mentioned in her presentation, we of course want to have process and balancing measures as well for each one of these. And then we want to test our rapid ideas of change. So whether it's training all of the managers who will then train the staff, whether it's posting our signage in different locations, we want to try some small PDSA cycles to see if by doing those things, if it actually does move our outcome measure and how clients report being able to act or know how to make a complaint. So again, that's just a very quick walkthrough of some of the tools in the model for improvement and how we've applied them at Simcoe using sort of flagged areas for improvement from the OPOC survey. But it's very quick and by no means comprehensive. So we're happy to have more conversations about that, and all of this information is available in the community of practice as well. My sort of takeaway from what I had to say is, the OPOC can be a great source of quality flags. It can tell you things that you really need to pay attention to from a client perspective, opportunities for improvement. And the QI tools and methods can help you drill down to the root causes of those flags, articulate what you need to measure, and help you generate some change ideas that you can try to then make improvements in those areas. And your improvements should be reflected in your OPOC survey data in future. And it's great to see things like the portal that give real-time access to your data so you can see if your change ideas are in fact having an improvement. And of course, QI is continuous, so it never stops. So at this point, I'm going to open it up to folks for questions and invite Kim, Kevin, and Chris back onto the line, and we can take some questions from the group. If there are any.
Great, thanks Mike, it's Kim. I just wanted to thank you and Chris. You both did a great job of sort of articulating different ways that the OPOC can feed into quality improvements. Chris speaking to it as a balancing measure, and you sort of articulating it as a way to sort of identify those big dot objectives. So the OPOC can help to identify the what, and then your QI tools and that drill down can help to identify the why, and what are the actions that you might take to be able to realize a positive change there. So that's really great. Thank you.
Thank you, Kim. Any folks on the line or on the chat who'd like to take advantage of these folks and ask any questions about your experience related to QI or the OPOC or the portal, or share any experiences you've had relating to the OPOC and quality improvement? Maybe as we just give folks a second to type in any questions if they have any, I'll just mention that we referenced the community of practice several times through the presentation, but here's how you can go about accessing that. You can either go to the link, the Health Quality Ontario link, or email at us at quality@equip.ca, and we can help grant you access to that. So that'll have the resources. There's some area for discussion and chats on there around issues or topics related to quality improvement, and you can also tap into our coaches via that forum as well. All the presentations and materials discussed today will be there on the COP. And if you'd like to learn more about E-QIP, there's some web site links here to both the Ontario CMHA page and the AMHO page, which have lots of additional resources. And similar to learn more about OPOC, there's a link here to the OPOC website where you can gather more information and resources as well. So I see there are some questions here on the board. So I'll begin by reading off the first to our group. The person is wondering if there's a way to have a walkthrough from tools we are already using, like the OCAN, and auto-populate the demographic data into OPOC, so we don't have to type it in again.
Great, Mike. I can try that one if you like. I think the thing to sort of stay grounded in is that the OPOC, as a anonymous measure of perception of care, is not connected to. So you wouldn't know if you're honoring the essentials of OPOC administration, you wouldn't know who that OPOC is connected to in terms of being able to auto-populate from a clinical assessment tool like the OCAN that is linked to the client as an individual person, that is linked to the personal health information within your databases, for example. So you wouldn't be able to auto-populate into the OPOC as a result of that. But one of the things also to note is that there's a couple of ways to administer the OPOC. Pen and paper is only one of them, but because of the central database, you can actually generate electronic links with a specific key for clients or patients to enter their own data. So in organizations where doing that data entry is a challenge, oftentimes they'll attempt sort of a hybrid model where they'll do some pen to paper depending on the client population or the program, if that is in fact the best way to get a great response rate. But then there's other types of programs and types of clients that have really been successful in using, doing the electronic data entry themselves. So you give them a link, or some programs have used tablets, etc. So there's ways to mitigate the data entry pieces, but you would never be able to link a clinical tool to the OPOC because of the expectation around client privacy and anonymity. So hopefully that answers your question. Feel free to type in some more if I haven't responded to the question concisely.
Great, thanks, Kim. The second question we received asks, I know we have to provide the OPOC in its entirety, but are we able to cross out the portion for inpatient clients if we do not provide inpatient services?
Yeah, great question. So this is something that when your implementation coach is working with your organization or your program specifically, they would help you to determine the best way to sort of provide sort of the upfront information to your clients or patients about it. it's articulated pretty clearly in the OPOC that those 6 questions can be disregarded if you're in community-based care. I'm just wondering if you're finding that some of your community or outpatient clients are completing the inpatient service portion. I'm asking whether that's a challenge that you found in terms of folks doing those 6 questions when they don't really apply to them. But in terms of your agency implementation plan, your coach can support you in deciding or defining some ways to articulate to your clients how they would complete the OPOC. That includes not completing those 6 questions if they're not relevant.
Okay, thank you, Kim. We have another question on the board. Is it the OPOC folks we talked to about arranging what you suggested? And sorry, that's in regards to the earlier question, I believe, because it's Rue as well.
Yeah.
And would that include the client portal that we have on site for folks to plug in their OCAN self-assessment? Can they also just use the same sort of technology to do what you have suggested?
Okay, let me try to make sure I'm getting the question accurately. So in terms of clients entering their own data, when organizations access the opoc.ca website and generate what we call a key is basically a code linked to an individual OPOC. It's what links it back to a particular program and a particular agency. But that key is a unique key linked to that survey, and you can give that key to a client. So the client could, if you have a portal on site that clients are using to do their OCAN self-assessment, as long as you have access to the internet, you can log on to opoc.ca, and there's a quick button to click that says, do my OPOC, enter my responses, and then the client would enter their individual key, and they would be able to enter their own data. So hopefully I've answered that answered the right question. And yes, you would talk to the implementation coach assigned to your area about that. And we'll make sure that you get, I think Mike noted that the slides would be on their community practice portal, but perhaps we can also send out the slides with those contacts to you, to anyone who registered, so you know who to touch base with.
Absolutely, we can do that. And Rue replied that perfect. They will all have access to the internet. Yes, you understood our question. So thank you, Kim. Do have a couple more minutes if there's any other last questions from folks on the line. Okay, and seeing none, I'm just going to ask folks, please take a moment before you leave today to fill out the survey. I will post that in the chat box as well as it's here on the screen. Let us know what you thought of today's session, and if there's other topics for future E-QIP webinars that you'd like to hear about, and we can try to make sure that those happen for you. Also, if you've been somebody who's done some quality improvement work in the sector and you'd like to share that with us as well, let us know. I'm sure there's folks who would love to hear about your work too, and we can help arrange that. Finally, if you have any questions at all, please reach out to myself or Sandra, co-directors with E-QIP, or if it's related to the OPOC, as Kim and Kevin mentioned, we'll share their contact with you as well after today. So, seeing no more questions, thank you very much to our presenters and to Jenna, who's been working in the background helping to coordinate this. And thank you everybody who attended, and we'll be sure to share all this material with you. Take care.
Thank you so much, everyone.
Thank you.
Thank you.